good afternoon, everybody. I will be doing a presentation regarding of two different articles. One article is regarding to personalized gene therapy, and the other is to an article related to cystic fibrosis. And here are my contents. The first article contents and the second article contents. In the first article, basically just will mention shortly about the story of the given article. It was a one page, but I go to references and find the full article of that. In the second article will be our major discussing article, the cystic fibrosis, its landscape, last few years, current status, current challenges, future directions, conclusions, and references. And to start with, as I mentioned, the one-page article, it was related to a research group. There was a newborn infant. She has a rare disease with carbonyl phosphatase synthetase 1 mutation. And this is an autosomal metabolic disorder that's here, as I show you. There is a here carbonyl phosphatase synthetase pathway, and due to the deficiency of that enzyme, the person cannot convert the ammonia with carbonate into the urea cycle. Therefore, the ammonia accumulates in the blood, and this further causes symptoms in nervous system, because nervous system is more sensitive to this toxic ammonia, and this causes intellectual disability, seizures, and other intellectual disability related dysfunctions. And research groups first this baby born and applied this gene therapy based on CRISPR technology. In 6 months, they achieved to fix this problem in the baby. And according to the article, at the initial stages, they only apply a few dose, in minimal concentrations, this therapy to see whether it is successful or not. And they find out this is successful. After 6 months, they started to increase the dosage of the therapy. And it was interesting to me because there is a newborn baby, and this technology is never before applied to anyone, and they applied it, and they have a success with that. In other case, the baby will tend to live with all symptoms in his or her late life. Here, that's all about the first article story. And now the main article, the cystic fibrosis. The cystic fibrosis, in the later slides, I will be explaining more about what is it and what kind of syndrome is that. But if we go back to the history in 1938, the scientist, I think it was the Dorothy Anderson, discovered that, and he named it as cystic fibrosis pancreas. And later, in that day, scientists also named this disease as mucoviscidosis, because this disease causes mucus accumulations in the lung and other tracts interior. But the mutation related to that, firstly in 1980s, they discovered the CFTR, cystic fibrosis transductance receptors, and in 2010 the newborn screening of that one started, and in following years, not very going back in 2012 and 2018 and 2024, the dual combinatory and trial combinatory drugs approved by the FDA. Here, first of all, the gold standard, how we detect cystic fibrosis with sweet chloride. A sweet chloride method is basically focusing on collecting the sweet from the patient and looking to the salt concentration inside the sweet chloride based on some scale and measurements. They find out whether the patient is really has the disease or not. For instance, if we divide the scale like that in 1 and 30 micromolar per liter, salt concentration is normal, and between 30 and 60 micromolar per liter concentrations turned as intermediate degree. But if you have 60 and above salt concentrations in terms of sweet chloride test, you have most probably have cystic fibrosis. And what are the complications? The complications are mostly related to respiratory system and lung diseases in cystic fibrosis, as I mentioned, the mucus accumulation and further interferences. And most importantly, thanks to the clinical trial networks, we have achieved a lot today. There are CF foundations, European Cystic Fibrosis associations, and drug trial societies. As I mentioned, our major molecule in the cystic fibrosis is the dysfunction in CFTR, the transmembrane conductance regulator. And to continue it here, I would like to present you this graph. This graph shows us how these CFF networks, clinical trials, foundations, and associations succeed to increase the life expectancy of the people. We can predict up to 5th decade year of persons with that disease. And we achieve to go beyond 50 years in terms of that in the years. And between 2016 and 2018, there is at least 2% increase in UK, according to article in the life quality of the patients. And here the last few years, the transformational change. In cystic fibrosis, here as I put to the slide, there are 350 CF causing variants identified from 2,000 of variants. The thing is that, you know, the phenylalanine is the main amino acid that has a role in cystic fibrosis. But the problem here is that even though this is a single nucleotide substitution, it is not same in all patients. It changes this single molecule, the location. That's the problem here. And based on the location and further interferences where this mutation causes problem in transcription, in translation, in intracellular traffic, in any function, the CFTR mutations grouped into 6 different categories. And the most common mutation is here, as I took the PHE 508 deletion. In the 508 deletions amino acid, this is the most common variant in all populations in the article in UK population. But I think this is overall in the world the most common variation. And what are the treatments? As I mentioned, in 2012, 2016, 2018, 2019, they start with the FDA approvals of the potentiator ivacaftor and CFTR correctors like Alexa factor, Tesa factor, Lumaka factor. But those drugs, like when they applied Ivaca factor, they observe the progress in the life quality, but the combination of the mutations push the researchers to create the combination of the drugs to achieve more successes in the treatment. When they take this potentiator Ivaca factor, the first approved drug, they combine it with the Alexa factor and Tesaco factor, or combine this with that dual strategy, this with that dual strategy, this with that dual strategy. But this is also not enough. They go to trios. They combine this with that, and they achieve more successes. And later, by looking to the gold standard, sweet chloride, they measure this quality increase. And what are the drug costs and how it changes between geography? According to the article in UK, annually 100,000 pounds just per year a patient have to pay for that. And this, as you expect, change from geography to geography, even in a regional part, not huge geography. To continue with current status of drug development clinical trials pipelines, not all patients answer the therapies. Therefore, researchers look to further therapy options. And what could be that? mRNA, tRNA molecules, mRNA and DNA replacement therapies. Here we have also gene editing like CRISPR, the most famous one. Here we saw three different examples. The company Translate Bio developed a lipid-based nanoparticle carrier for mRNA delivery. You know, lipid nanoparticles gives us the success that you put your mRNA into a capsule and make it travel to a specific tissue, a specific part in your body. And Gene Therapy Consortium, Boehringer Ingelheim, Oxford Biomedica, developed a therapy that targeted cystic fibrosis with pseudotype lentiviral vectors. What are pseudotype lentiviral vectors? They are these pseudotype lentiviral vectors are viruses that have specific glycans on their surfaces. Most commonly, maybe we know from our biochemistry courses, the spring flu, like every year we aşının İngilizcesi ne, ben arada unutuyorum. Vaccinations. Every year in the flu, we have flu vaccinations, and we try to adapt to viruses, change these glycan structures in our flu vaccinations. And the last one, here in our examples, not last one, for the molecular therapeutics, spirovind, adeno-associated vectors. Adeno-associated vectors are the most significant candidates. They are non-enveloped viral vectors that give the ability to transfer as part of DNA fragment to deliver a DNA fragment to a specific location. And other strategies here, the antibiotics, biofilm, and as I mentioned, the bacteriophages. Here the important thing is that in cystic fibrosis treatment there is a problem. Even though you have very good candidates, very good drugs, during the treatment, if you have an infection, this disrupts all your treatments. Therefore, you have to, the doctors, the physicians, have to prevent you to become more prone to infections. Therefore, here those antibiotics and other strategies have a significant role, especially the biofilms. Here, just an overview what I have talked about. Maybe we can add from here the nitric oxide channels, interesting to me because in our neurochemistry course we also mentioned about them. They are very significant player as a secondary metabolites, and they also used in those treatments, and as well as I told you, anti-biofilm for to prevent both infection and develop further strategies could be significant, and antibiotics. To continue it here, we increase the life expectancy of the patients, but this becomes with trade-offs to us. Let's say you increase from 40 to 50 or from 40 to 60. Other symptoms comes to the stage, and you have to track those symptoms. As I mentioned, new health problems comes to the stage. One of them is the increased risk of gastrointestinal cancer, and therefore physicians suggest for a colonoscopy after the age of 40 for those patients. But in the article they mentioned if specifically for 40 and above, if you are a patient in 30 age, they don't suggest that. Another trade-off could be that if you slow down the disease, your sensitivity decreases to track this disorder. You have less ability to monitor the disorder. That's another trade-off here. And as I mentioned, not all patients accept this treatment. It's not about personal choice, but the mutations they have, the tolerance, like the absorption rates based on concentrations, prevents the patients to take those therapies. And here the legal things like reimbursement, whether I'm not sure about that, but I'm not sure if the government paid for you or your personal pay or repay about this reimbursement. And here there is a Julien Linda Association for Priority Research. They said, okay, we achieved a lot coming back from the history to today. We achieved a lot, but today we still have problems. And what could be our priority in CF? And they make a research with 600 different contributors from 30 countries. They ask to the people with cystic fibrosis, to their family members, to the clinical care teams, and they decide as a topic, we have to reduce the burden of treatment. And this is only possible with personalized medicines and personalized therapy. Here I wrote the theranostics. Theranostics, when I research about it, is related to nuclear medicine term, but in the article, like they say, we have to prior collect ex vivo tissues from the patient and apply our drugs and therapies to those ex vivo tissues to reduce the burden of the treatment. And this was really logical and interesting to me. And today there are like CF Storm and CF Star drug trials going on. Here there is a table of sorry, I have to look my notes. The outcome survey of those therapies. Here at the first column there is a forced expiratory volume in 1 second. They look to the this ratio. This comes with pros and cons, like in pros whether it is performed routinely or not, but this is good in terms of they can make this clinical study in lab or remote, in remote with home spirometers. Their cons, they cannot track this method in patients with mild lung disease. And most suitable populations are the adults or children with moderate to severe lung disease. And the conclusion is like the 2 slides before we discussed, the Julia Lind Associations for Priority Terming group in cystic fibrosis. They would like to come with more strategies to the patients who cannot answer those CF. Therefore, the strategies I have just talked about, the mRNA, new mRNA, tRNA drugs, mRNA, tRNA-based drugs, DNA repair related mechanisms, and directly mRNA and DNA overall replacement could be a good strategy to help people who not receive the treatments. Here is my conclusion. And just would like to, if I miss anything from my notes, I should talk about it before ending my presentation. Sorry for that, if are there any significant things. I think that's all from me about cystic fibrosis. Thank you for your attention. Here are my references.